Good morning, everyone, and welcome to this Ask the Doctor Zoom discussion with Dr. Jean Christine Yee. I'm Michelle, or Mickey McWilliams, and I work with Sid Moss, who's up here too, at Cure Multiple Myeloma. Before we begin our discussion, I'd first like to thank our very important partners, Bristol Myers Squibb, GSK, and Sobi. Without them, we wouldn't have the great resources to reach out to multiple myeloma patients and provide this great discussion platform. I also want to acknowledge Sid, the founder of Cure Multiple Myeloma Corp, and let you know that since we are doing, except for this one, since we're doing our discussions both in person and virtual, we're not going to give you breakfast treats. So sorry, but I just encourage you to come to the rest of the discussions in person. We will be serving food there. We're so pleased to have Dr. Yee with us today, Associate Professor, Department of Lymphoma and Myeloma at MD Anderson Cancer Center in Houston, Texas. Dr. Yee earned her medical degree and master's degree in China. She completed her internal medicine residency and hematology oncology fellowship training at Wayne State University. Dr. Yee specializes in medical and multidisciplinary management of plasma cell disorders, including multiple myeloma. Her clinical and research interests have focused on developing innovative therapies and identifying novel biomarkers in myeloma management. She leads or co-leads national cooperative groups and industry-sponsored clinical trials. Dr. Yee serves as the vice chair of the NCI SWOG Multiple Myeloma Committee. So today, let's start with Dr. Yee's very busy year. She moved from U of M, I'm trying to do this two things at once, to MD Anderson in Houston. Dr. Yee, can you please fill us in?
Thank you, Mickey. It is such a great pleasure to see everybody again. We did this type of talk when I was still at the University of Michigan, and now I'm in Houston. So it's no longer that early for everybody because we have 1 hour time difference. So as Mickey just introduced, I used to work at the University of Michigan as a myeloma specialist, and I moved to Houston recently and at MD Anderson. So my role, pretty much national role, and also my practice and research activities, very similar to what I have done at University of Michigan. So it's so nice to be able to sit here and then talk to you. And first of all, I would like to congratulate Sid for his great achievement and contributions to the myeloma community and his recent award from MMRC. I think this is such a great partnership and to put patients, families, and also providers together so that we can serve the myeloma community. And that's all what we are here for. Congratulations, Sid.
Thank you.
And what I'll do is I can put in the chat the link to what's going on with Sid in this this run that's coming up, the MMRS run. So if anybody wants to join, come to the run, or if you want to, just make a contribution or whatever, I will stick that in the chat.
Okay, great. Hopefully everybody can make it out for this year, because I remember last year there was some rain in the middle. So hopefully this year it is the weather will cooperate. So I think we have a dozen of people already in a meeting. Happy to answer any of the questions. Multiple myeloma, this disease evolving very quickly in the field of both treatment. I think most of the patients are probably focusing more on the treatments, but in addition to that, certainly diagnosis, and also we're trying to look for some of the biomarkers to help us to identify which treatment is better for which patient. But we are still not there yet. Precision medicine is something that we are always hope that we can utilize that as a tool to help patients, but currently probably very limited in multiple myeloma, this disease. But a lot of clinical researches and also translational researches hopefully can help us to get there. One of my personal research interest is to look at the immune profile for patients in both microenvironment, meaning in the bone marrow, and also in the peripheral blood. It serves the purpose of one is we try to get patients into remission. That I think is the ultimate goal. If we are able to cure the disease, that would be even better. But before we can achieve that, if we are able to help the patients to get into remission, I think that is the very first goal that all the patients are aiming for. So sometimes we actually discuss with the patient at each visit, especially before each cycle of the treatment. We would help a patient in the clinic to evaluate for disease response and also side effects if you experience any. So keep the balance of response and also side effect. This is what we're trying to discuss with the patients at each single clinic visit. By saying that, I think most of the patients probably heard about minimal residual disease. So when we evaluate for the disease response, we oftentimes tell patients we actually have different criteria trying to classify the patient into different categories of response evaluation, meaning some patients may achieve complete response, some patients may achieve a partial response, and some patients may actually achieve the best and the deepest response we can measure so far, which is called MRD, minimal residual disease response. So by saying that, actually, in a lot of researches, we found that some patients, if they achieved the deepest response, they actually can stay or remain in that remission status. But some of the patients, even though they can achieve sometimes minimal residual disease, which is the deepest response, as I mentioned, but may still relapse. So why is that? And so there are a lot of questions remained. So that's why I'm interested in learning the immune response. One school of thought is our immune system actually plays an important role in that. And sometimes in some of the patients, arguably, so I know every patient is trying to get into the remission and as deepest as possible. But in the clinic, we actually do observe some patients, they actually always have a little bit of the residual disease measurable at a low level. However, they actually don't have the disease progression and they are able to remain in that status for a very long time, like measured by years. So that's why patients can do that. So those are the research questions that put into the context that I was just mentioning, that I am interested in learning, the immune profiles of the patients at the level of the bone marrow, which we call microenvironment, and also hopefully in the peripheral blood we can identify something that can correspond to the bone marrow and figure out if there is any markers, immune markers that we can identify to understand whether or not this patient may have disease long-term remission or may have disease relapse soon. One school of thought, as I mentioned earlier, is whether or not the immune system actually plays more.
You're going to do the Lanai, or you want me to?
Yeah. If our audience is not speaking, maybe you can just mute yourself so that it won't interfere with our conversations here. So immune system sometimes can constrain the disease, even though there is a little bit of the residual disease there that could happen in some of the patients. By saying that, I know like most of the time we are trying to drive the remission to the deepest as possible. That's still what we are trying to do, because there are still a lot of unknowns right now. But researchers are going on every day in all the labs, and hopefully we can get new discoveries, and the ultimate goal is to help the patients for disease management. That's actually part of the lecture I'm actually giving to our fellows, and there are so many steps from the lab, from the bench to the clinic at the bedside. There are so many steps in between, and usually the drug discovery or the biomarker discovery takes years to develop. However, I think we really have to do it. So here I probably would encourage all the patients, if you're interested in clinical trials, whenever they would like to ask for the research sample, if you are willing to contribute and give us some of the extra samples, so that we can study whether or not this is correlated with a better response or suboptimal response. Those are all the research questions we have, and hopefully can help not just experiments in cell lines and mouse models, but also for ultimately in human diseases, because the microenvironment in the petri dish and also in the mouse microenvironment is actually quite different from human being. So ultimately, we still need to study in patients. So with that, I think we do have. Oh, those are just the information in the chat box that Mickey put for the 5K walk.
I have a couple questions that came in early. I asked those that are here to send me some questions, and I do have one from Hal. What he would like to know is, what is the latest guidance on COVID vaccines for multiple myeloma patients?
Yeah, so COVID vaccine, actually, we strongly encourage all the patients to get it. I think your question probably is like, how many doses, timing of those vaccinations. Those are most commonly encountered questions in clinic. So we usually actually go by CDC guidelines in terms of like how many boosters you should get. And always for myeloma patients, unless patients are like AMGA smoldering, I don't count those patients. I'm talking about most of the myeloma patients that you are going through the treatments. We do follow a CDC guideline, but you will be in the category of so-called immune-compromised patients. We all know that multiple myeloma disease itself actually, it's a disease of the plasma cell, and the plasma cells are the terminally differentiated B cells. So B cells are part of the immune cells. Usually they actually, they are part of the immune response, immune defense to fight for infections. So myeloma disease itself, because it's involving the plasma cells, so disease itself already puts you at higher risk of infection. And also, whatever treatments you're getting, you probably heard from your doctors, all the drugs, when we talk about consent with the patients and also the side effects, risk of infection is always high. So many patients actually, sometimes we say, even if their disease is well controlled, they may sometimes die from infection. So you can imagine infection is actually quite important for us to consider how to take care of patients while balancing the side effects. So with those two reasons, vaccination actually is very important for our myeloma patients. Not to mention, some of the patients actually are post-transplant. So they actually have to redo their baby vaccinations all from scratch. By saying that, bottom line is we do encourage you to get COVID vaccine and also the boosters according to CDC guidelines. A couple of caveats, timing. So when you are getting, for example, the new line of therapy, for example, starting with new treatment with daratumumab, for example, which Dara is a commonly used drug right now. One of the potential side effects is infusion reaction, and then they can present as some of the overlapping symptoms with the vaccination, sometimes as side effects. So that's why we actually encourage the patients not to have the vaccination on the same day of the initial dose of Dara. I think infusion reaction for Dara usually it's the first dose or the second dose. And usually if you're tolerating well, you no longer have those side effects as infusion reaction. So we usually encourage the patients not to have the myeloma treatment and the vaccination on the same day. Try to space them out. That is how we advise for the timing. Some of the patients, when you are going for CAR-T, when you're going to the bispecific antibody treatment, for example, teclistamab, this is a newly approved antibody drug. And it can have the side effects of CRS, it can have the side effects of neurotoxicity, it can have like different types of side effects. So during that time frame, especially the first few doses, because for example, for TEC, you actually have the priming dose, which is the testing dose, followed by the full dose. So during those time frame, we actually do encourage patients not to have the vaccination because of the potential overlapping side effects. When you have the side effects from the myeloma treatment, oftentimes the doctors have to look into why you're having those symptoms, how to differentiate from this particular study drug or the new drug versus the other reasons. So try not to complicate or cloudy the picture. We try to separate the vaccine from those new treatments. So those are the concerns that we usually would put into consideration when we advise the patients for vaccines.
There's another, Jerry just put something in the chat.
Okay.
How soon do you think peripheral blood tests will be able to replace MRD testing?
That is a very good question. Actually, that lines up with the correlative studies that I mentioned earlier for a lot of clinical trials. We're still trying to find that out. Some preliminary data actually from different groups. Some of them, they say there might be some of the correlation we can identify, and some of the other publications mentioning there's no direct correlation. So it's still too early for us to say that. By saying that, in the peripheral blood right now, there is a mass spec as the new type of MRD testing. So currently, the standard of care for MRD testing approved by FDA is to use your bone marrow samples. So we measure those plasma cells, those myeloma plasma cells, directly in the bone marrow. And there are two ways to do that. One is to use the NGS next generation sequencing, and the FDA approved clonoSEQ is one testing that we actually can do by sending the bone marrow samples. Another way to do that is to use the same type of sample from the bone marrow, however, to use the next generation flow cytometry to measure that. And then that can actually be achieved by many academic hospitals, for example, University of Michigan, MD Anderson. We all have those flow cytometry that can have the capacity to do that. As a matter of fact, the flow MRD at University of Michigan, I actually introduced that into University of Michigan and established that with Dr. Boyer, who is the director of flow cytometry. So it is available in major hospitals or cancer centers. However, compared with next generation sequencing and the next generation flow using the bone marrow samples, this is always there are different advantages and disadvantages from using either of these two technologies. But to address the question of like peripheral blood MRD, that is actually a different type of testing. This is not to use the same type of testing that I was mentioning for the bone marrow samples. This is actually to use the peripheral blood using the mass spec. It is to measure the protein levels. So right now, in the clinic, when you go to your doctor's office and evaluate for the disease response or disease status, your doctor probably sometimes will show you your protein levels from the lab work. Those are standard of care. Most commonly used are, one is called SPEP, serum protein electrophoresis. One is called serum free light chain. And another one is called immunoglobulin level. Those are the three most commonly used. Now, you probably heard about like immunofixation. Those are different. Those are not to measure the protein level. Those are used to identify the types of the protein. So those three tests that we usually use in standard of care to measure your protein levels, certainly there's limitation for the sensitivity. So when your protein level is very low, we sometimes say, okay, this patient achieved a complete remission. That actually is based on, partially based on the protein levels that we're no longer able to detect using those three quantification blood work that we are able to use right now. So mass spec actually, that can offer more sensitive tests compared with those standard tests. So that's why this has been introduced and used to measure so-called minimal residual disease. However, keep in mind that that is indirect measurements for the myeloma disease. This is for protein, not for the myeloma cells in the bone marrow. So those are the differences. All right. Hopefully, so right now it's not it's not approved by FDA as like a standard of care yet. So it's still like in the stage of clinical research, but certainly like because it's more sensitive, so it can give information in terms of the lowest possible protein level that we can measure nowadays is to use this mass spec.
Hal put another question in the chat. Is DEX being phased out as part of combination therapies?
Yeah, Hal, I think that today is the first time that I know you before this like a Zoom meeting. You mentioned that you were a patient diagnosed when you were in Chicago. So I'm so happy to see that you've been in this journey for such a long time, and certainly you have a lot to share with the other myeloma patients. And you are asking a very important question, I have to say, that patients hate it, and then myeloma doctors try to eliminate that as well. But let me explain to you why we did not eliminate dexamethasone. Obviously, from patient's perspective, it does have a lot of side effects, short-term, long-term, right? Even though it's not a daily use, it's usually weekly use or sometimes twice a week, depending on which regimen you are on. And it can cause, for short-term, high-dose steroid, can cause stomach issues, sleeping disturbance, can cause mood changes. Sometimes we call this steroid range, and family members hate it. And can cause the fluctuation of the blood sugars, especially for diabetes patients. Sometimes they even can have blurry visions when the sugar level really fluctuates. So, so those are the side effects that we truly don't like them. However, dexamethasone so far, it is one of the wonder drugs that can help control the disease very quickly. And really short term, it is very helpful. Now, why we are using this for all the combination regimens, there's always historical data, right? That we, because we don't have the money and the manpower or enough number of the patients to do all the trials we want. And a lot of clinical trials are based upon the previous clinical trials. And because dexamethasone has been incorporated into pretty much all the triplet regimens, and nobody wants to do a clinical trial without dexamethasone, and this it's just not balanced with the new new control with the new combination cohort. Because usually for phase 3, for example, this is the standard kind of NCI, National Cancer Institute, approved way of saying one regimen definitely is better than the previous regimens. So when you design those type of trials, because in a SWOG, myeloma committee, for example, when we discuss how to design those clinical trials, we always have to keep in mind how the previous trials were conducted and how what is the current patient population we're trying to do this trial, and then how we can balance these two trials to reflect the current standard and also the future standard. And then by saying that, you have to design a trial that balanced with the previous regimen. You cannot have too many variables, so that that would interfere with the interpretation of the data. So because of those historical reasons, I think dexamethasone has been incorporated into pretty much all the new regimens, new study regimens. Now, it doesn't mean that we are not making effort to eliminate a drug with a lot of side effects, right? So in our clinical practice, for example, for the maintenance therapy, we usually actually drop dexamethasone. If your disease is well controlled, there's no reason for us to continue dexamethasone. So that's usually how we do it. Actually, I will be chairing a phase 3 study from SWOG, which is for newly diagnosed multiple myeloma patients, frail patients. You know, the average age for onset of this disease is around 65 and above, usually around 70 years old. And those patients, many of them, they actually have a lot of comorbidities, meaning other medical problems like heart problems, lung problems, kidney, or liver problems. So for patients with the other medical problems, we have to be extremely careful for those patients when we give myeloma treatments, because all those regimens that we treat the disease may have side effects. So for those patients, actually, this trial is trying to consider those real-world patient population, more frail patients, and how we treat them, try to help them to achieve the response, the best response if we can, using the more novel agents, but at the same time to minimize the side effects. So for that trial, when we design that trial, we actually only give patients in the induction, and then we quickly drop dexamethasone. So by doing that, we do have the reasonable control with the current standard of care, but also give patients the best response if we can at the initial induction therapy phase. However, once their disease is better controlled, then we can drop dexamethasone. So thank you for asking this important question. It's not we're not trying to to do that, but there are different reasons, and also the timing when it's safe to do that. So those are all the consideration.
My induction therapy was VAD back in 1998. So I was getting 40 milligrams of Dex 4 days in a row, 4 days off, 4 days in a row, 4 days off, 4 days in a row, every cycle. So, I learned to hate Dex.
I heard you.
course,
I
no-
totally agree with you.
Of course, I was very excited when they just determined that low dose Dex was just as effective, and you had less side effects, of course, and people actually lived longer if they had low dose Dex rather than what I went through back in 1998.
So Hal, fortunately, I think for more recently diagnosed with myeloma patients can testify that we no longer use this regimen you had back to 1998 for the current induction therapies. We now have, because at that time you only had chemotherapy. So nowadays we have many chemo-free like agents available for induction therapy. Even though we still incorporate the DEX into the clinic, into the regimen, but usually they most often, I have to say, is they are getting weekly dexamethasone, for example, with 40 milligrams once a week, and sometimes we split them to 20 milligrams day 1, day 2. So that can try to minimize the side effects. So the only time that we still use a little bit, I don't use more than 2 rounds, is like 4 days on, 4 days off. And usually I actually only use 4 days, is when the patient, when they walked into the clinic and they have full-blown picture of the multiple myeloma with high disease burden, impending kidney failure, or already starting to show kidney failure, or they had cord compression because of the myeloma plasmacytoma compressing on the spine. Those are the situations I actually do use 4 days on, 4 days off, this type of treatment, just to give the myeloma disease a very quick disease control if we can, because all the other and sometimes they have to get the radiation therapy. We cannot get all the regimens right away, and also Revlimid, all those oral drugs, may take time for the insurance approval. All those reasons that we still use dexamethasone for very short period of time and very cautiously. So thank you so much for sharing your experience. To be honest, I feel like your diagnosis was way back before I know about multiple myeloma. So oftentimes I tell my patients that I actually learned the disease from you. So thank you for sharing.
It looks like Neil McMichael has put a question in the post. What is the best use of IVIG infusion therapy to increase antibodies to minimize the side effects of Revlimid and other treatments, which may contribute to low platelets or chance of infections?
So maybe I can just explain a little bit of when we use IVIG. So for us, we call this indications for using IVIG. So IVIG for multiple myeloma patients, we use it when the patient's having the combination of these 2 factors. One is low IgG level. Usually it's below either 500 or 400. Another is when the patient's having frequent infections and also catastrophic severe infections that are requiring admission to the hospitals for IV antibiotics, sometimes even in ICU. So those are the patient population. With the combination of these 2, we do consider IVIG. Now, keep in mind, remember I was talking about earlier, there are 3 tests that usually give us the quantification of your protein level, those bad protein levels in the blood. And IgG level could be part of it when your disease is IgG type. Certainly it could be like kappa, lambda, like those restricted light chains. But talking about that, because some patients have IgA disease, some patients have IgG disease, right? So for IgG type of patients, this quantification could be part of it. So sometimes it could be a little bit confusing for patients. Now, by saying that, once you get the treatment, your level of those protein levels usually would go down, including IgG if you have IgG type. And when it is high, actually, your insurance company will not approve using the IVIG. So that's why the cutoff of like 400 or 500, depending on which hospital or which insurance company, usually in that range, is the threshold that they would approve it. And then arguably, we don't give IVIG to all the patients with low level of the IgG level. So some of the patients would ask why, because some patients actually tend to have lower IgG level, but they don't actually get like infections somehow. And then usually we do not routinely use IVIG for those patients. By saying that, you mentioned that the platelet count. So platelet count is in a different category. So usually, I explain to my patient, in your blood, you have 3 big groups of the cells. You have red, white, and the platelets. The red cells, like you usually look at your blood work is using hemoglobin to measure your red cell levels. White cells, you have neutrophil, you have lymphocytes. And earlier I mentioned lymphocyte, terminally differentiated is the plasma cell, which is your multiple myeloma disease. Now, neutrophil is important and the lymphocytes are important. They work together as part of your immune system and immune defense to fight for infections. So when you have infections, it could be low neutrophil count or it could be low lymphocyte count. Okay, so this actually is the cell group that your doctors actually monitor very often. And when it's too low, sometimes they have to consider how to adjust the medication, including Revlimid. Revlimid actually is known to have one of the side effects is to lower your neutrophil count. All right, so that's why this is the consideration when your doctor would consider the dose reduction or interruption of the treatment. Now, platelet count, the third group is platelet count. This is not in the same category of your white cell count. So this is not a part of the consideration for IVIG. All right, so hopefully I'm able to help you to clarify a little bit of the group of the cells when we consider what. Is that helpful? Is there any further clarifications you would need, Neil?
Neil, we
Sorry.
can't hear you. We can't hear you.
Okay, if I don't hear from you, I assume that it's clear to you now. If any other group members feel not clear enough, I'll be happy to reiterate. But those are different groups of the cells that we look at for considerations of IVIG. All right, I saw another question from Jerry. Some doctors think you should not get MMR vaccine following stem cell if you are on DEX, while others think it's okay to get a vaccine even you are on DEX. MMR vaccine actually is different from the other vaccines because there is a component of live vaccines, I believe, and stem cell transplant. So actually, I'm not the best person. I don't want to pretend to be the infectious disease doctor. So just to share with you some of the limited information or knowledge that I have, because we are all trained from internal medicine, but after that, we actually get into different subspecialties. So we have a group of doctors, infectious disease doctor, that they actually, they are more the experts on this topic, but very superficially and briefly, the concern of dexamethasone when you get vaccination is because sometimes dexamethasone actually can suppress your immune response actually. So dexamethasone belongs to steroids, that disease drug category, and if you heard about a lot of like autoimmune diseases, we actually do use steroids to treat autoimmune disease, which is to suppress your immune response. Because autoimmune disease is just like your own immune system got activated, right? So we use steroids to treat those patients. So that's why that can like decrease your immune response to the vaccination. So that's partially because of that. But I would say it would be a better question for infectious disease doctor because they are the experts on the vaccines. And if you get a chance to talk to your either myeloma doctor or even your primary care physician, if you have this type of questions, I think they will be happy to refer you to a specialist.
Christine, I made a mistake. I was actually referring to Dara, not Dex. Daratumumab.
Oh, okay. So daratumumab, I think that's probably because of the reason that I mentioned earlier for pretty much all the vaccinations, that when we give vaccinations, Dara potentially, especially the first couple of doses, that potentially can give you infusion reaction. And we try to avoid the overlapping side effects. So, so we don't have to kind of like have to concern like this type of symptom is from Dara, and then we have to like eliminate this drug or hold the treatment. I think that is the concern if you do them together. Now, keep in mind, there's another caveat. Daratumumab is a CD38 monoclonal antibody. To some ways, one of the side effects actually from daratumumab is actually increased risk of infection because this drug actually can deplete B cells. So in that regard, because B cells are the cells actually generate those antibodies after the vaccination, sometimes that is a concern. Now, in the past, when patients getting vaccinations, when the treatment is on another drug called Rituxan, Rituxan is anti-CD20 monoclonal antibody, which can deplete B cells. So in the past, there is a concern when the patient is getting Rituxan, we advise the patients, actually, it is more commonly used in lymphoma. So lymphoma doctors would advise the patients, you probably won't get immune response if you are getting the Rituxan and wait until 6 months after Rituxan is completed, and then you get vaccination. So there is similar kind of like a thoughts for daratumumab because of the similar B cell depletion. But for that, myeloma doctors have not advised the patients to wait until 6 months before you get vaccinations. And some doctors will say, even though there's data that B cell can be depleted after Dara, however, you never know. There are still some residual B cells there. And if the patient can get protected, even though it's not the full, they cannot amount the full potential of the antibody response to have the high titer of those antibodies from the vaccination, better than nothing. So they would still like ask the patient to get vaccination to help the patients. So that's why we don't have all the data, and it's interesting because ASH is actually thinking to do more like studies for COVID vaccinations. Hopefully we can learn more for different like patients because their project actually includes multiple myeloma patients. So hopefully.
I did have a question that Neil sent in earlier. His question is, what are the best treatment options for a patient with a dual diagnosis of multiple myeloma and AL amyloidosis?
Amyloidosis. Yeah,
Okay.
I heard you. Yeah. So this is a good question. Oftentimes, so these two diseases actually are almost like I call them sister diseases. Why is that? Because both of them, they are caused by bad proteins. And there are different disease presentation and also disease involvement in the organ for these two diseases. Multiple myeloma disease, mainly the plasma cells, they live in the bone marrow, And those bad proteins are secreted by those myeloma cells. And usually the organ involvement include kidney, bone, anemia, and also sometimes high calcium level because of the bone lesions can release the calciums. Versus amyloidosis, this is a disease actually, it's misfolded proteins, and those proteins actually deposit onto different organs. Most commonly involved organs include kidney, heart. Those are two most commonly involved. And also it can be in the GI system. Patients may have protein deposit in the stomach. They can have constant nausea, vomiting, or in the gut and cause like constant diarrhea. And sometimes can be in the liver and causing liver dysfunction. And it can also be in the lung, some patients, and especially the lining of the lung, we call pleura. So amyloidosis, because this disease is so rare, very rare, and it's very hard for us to conduct the clinical trials. So a lot of regimens for AL amyloidosis treatment actually is from multiple myeloma. Now, amyloidosis actually has different types of amyloidosis. So AL amyloidosis is the one that related to myeloma. But the other types of amyloidosis are probably different. There are like senile amyloidosis. There are different types. So when you treat, so some patients may have just myeloma. Some patients may have just amyloidosis. Some patients may have both. When you have both, we actually do look at which one is more dominant. So because we borrow some of the regimens from myeloma to amyloidosis, but not all of them. So when you have amyloidosis dominant and a very low amount of the bad proteins, we actually just treat as amyloidosis as such. And usually it will be induction followed by transplant without maintenance therapy. That was not well established. Versus for multiple myeloma, now we actually have many more options available, even for induction therapy. So that's why when you have both of these two diseases with myeloma more dominant, then we actually have more options just to treat multiple myeloma. And at the same time to see how you're responding to both myeloma and amyloidosis. So this is actually quite complicated. And your doctor really has to dig into a lot of details because the organ involvement. And for myeloma, we usually say disease response, we measure the proteins, we measure the plasma cells in the bone marrow, versus in amyloidosis, you also have to evaluate for organ response because different organs can be involved and those are part of the evaluation as well. So that is quite complicated, and I would strongly encourage you to have thorough discussions with your doctor.
Yes, I went to, I was diagnosed back in 2018. I went to the Cleveland Clinic, and they first diagnosed the AL amyloidosis because I was having issues with my heart. Like you said, there was fibrils that were breaking off and attaching to my heart and making it stiff. And I was actually having symptoms that seemed very close to a heart attack. And then when they did a bone marrow biopsies, when they found out I had both AL amyloidosis and the multiple myeloma, and they put me on the Cyborg-D regimen, 6 cycles, and that helped a lot. Then I had a stem cell transplant in July of 2019, and I've been on maintenance ever since and doing well. I was just wondering what your experience is with the dual diagnosis. Thank you for your comments.
Oh, you're very welcome. I'm glad that your disease is well controlled right now. Because currently for amyloidosis, all the treatments that we offer to patients, for example, the Cyborg-D that you received, is just try to lower or reduce the production of the bad protein. However, we are not able to remove whatever proteins, the misfolded proteins deposited onto the organs. We're not able to eliminate those. So that's why there are a lot of research going on. But I'm glad to hear that since 2019, because it has been 4 to 5 years. So I'm happy to see that.
Almost 5 years since my diagnosis.
Yeah.
I was MGUS back in January of
Mhm.
2018, and then I was diagnosed in October with both. But they found it very early in stage 1A is what they diagnosed me at originally. And I took Revlimid and Dara last year, and now I'm just on Dara only and doing well. Thank you.
Yeah, you're welcome. Dara was just approved last year for this particular drug for particular disease. Again, borrowed from multiple myeloma. So I'm glad that it's helping. Okay, great.
If anybody else has any questions, you can just unmute and ask them too. Because yeah, I don't see any more in the chat, and those are the questions that I had. So just speak up or raise your hand or whatever if you've got some questions.
It seems not. I know this group is well educated by a lot of not just your own doctors, but a group of doctors like me who actually like regularly chatting with you. So I wish everybody the best of luck at any time. If you have any questions, feel free to reach out to us. Even offline, we will be happy to give you some general guidance. Certainly, we cannot replace your own doctor, but happy to help in whatever way we can.
That is so generous, and I think that everybody here appreciates that, because it is something that this disease, at least to me as an onlooker to this disease, it's moving so fast. The treatments are there's so much every time we have a new conversation like this, it seems like there are new therapies or changes in the way that that therapies are approached. So it's really, I think it's a really wonderful thing that that doctors that are like you are willing to come to meetings like this and answer people's questions. It's really, thank you. Really appreciate it.
Oh, you're very welcome. I'm so happy to be part of the myeloma community in Ann Arbor, and I just feel that's why when Mickey reached out to me, even though I moved, I said, well, I'm still happy to be part of the local community in Ann Arbor, and I still had a lot of patients over there. So I wish everybody the best of luck, and whenever you need help, there are experts that not just working in the clinic, seeing patients, doing research, trying to get more answers, but also readily available for you.
And if you want to reach out to Dr. Yee, you can always ask me, to do that too. I'm happy to, put you guys in contact or do whatever is necessary.
All right.
Great. Thank you very much.
Yeah,
You're
thank you,
very
Dr. Yee.
welcome.
Thank you
Yeah.
so much.
We
You're very
appreciate it.
welcome.
And actually, it's just about the time that we need to go. So so thank you everyone for joining this conversation, and look forward to seeing you. Hopefully, we'll see some of you in person with our next talk too.
All right. Thank you.
Okay.
Bye now.
Take care, everyone.
Take care. Bye-bye.
Bye.